Alright, can you guys hear me okay? Sorry, I got a little cold over the weekend, so make sure you guys can hear okay. I know a couple people brought their phones up here. Last chance is today to look at these exams. I think most of everybody has looked at them, so if there's any questions or any comments, just let me know by the end of today. Other than that, that's the grades that we'll go with. Kind of gives you an idea for the format for the other exams as we move forward as well, okay? So now we're going to shift gears. We're going to talk about the abdomen down into the pelvis over the next 3 weeks. Today we will briefly mention a little bit about male and female pelvis, but we will have a separate class just for the female pelvis. I think it's the 3rd week of this block. So at first, when you look at the abdomen, I know that we have the 9 regions and we'll mention them to be complete, but unless you're going into some type of general surgery, these regions aren't used as often, okay? But if you look along the midline, of course, you start just below the xiphoid process, you're introduced to the epigastric region, and that'll make a little bit more sense to us when we look at some of the blood vessels that are running in this region, sort of the superficial vessels. So there's an epigastric and umbilical right around the belly button, and the pubic. So then on either side of that, you'll notice that you have the flanks sort of along the midline, you have the groin area, and of course the hypochondrium, the right and left up above, along with the epigastrics. So again, I mean, at this point, these are just names, and it's more or less just memorization as far as which one of these names associated with which one of these regions. But some of it does make sense, of course. The umbilical, the flank, pubic region, groin. To me, I always thought the groin was a little bit pretty far lateral, because you always think of your groin being a little bit more medial. But according to our diagrams, when you look at sort of at the plane of the nipple downstream towards the middle of the inguinal region, that is your border. So the actual groin, there's not much involved with the groin on either side. The pubic region takes up most of that area. But most of what we deal with are the quadrants. I think most people, I mean, you look at that before you really look at any of the true 9 regions. So when you think of the quadrants, you think of like left upper, you think stomach mainly sits in that area. Right upper, you think there's a lot of the liver. Right lower is big when we think of things like appendicitis. So the appendix lives down in that area unless it's inflamed, and then it can head elsewhere. And then the left lower. All of this has some of the small bowel, all of this has some of the large bowel associated with it. So when you start talking about the quadrants, you're looking for a little bit more specific organs that are living in that area to sort of localize them a little bit better. But this is just sort of like the big picture, the big overall. Now, if you take this from a dissection standpoint, you look at the skin, and then of course you have the superficial fascia, and then we head downstream past the muscles into eventually what'll be the belly. But with the skin, you'll notice in this area that as soon as you reflect the skin, you're introduced to a couple of fatty levels that you'll see here. There's a superficial, there's also a deeper that we've seen a little bit with the muscles already. But the superficial fascia in this region has a specific name called Camper's fascia. Okay, the Camper's fascia, and the Camper's fascia will continue downstream, especially in males, down towards the scrotum. So you're introduced to it here as the Camper's, but it's the yellow lobulated looking fat. It's the same fat that we had everywhere else that we've seen so far, but it has a very specific name. And then sort of within that, this diagram doesn't do a great job of this. It does mention it, the Scarpa's fascia. It does mention it, but it doesn't do it justice, because the Scarpa's fascia is sort of, it's a sheet that's interwoven within the Campers. So if you scrape away the Campers, you see a collection of this Scarpa's fascia. Only then does it actually look like a true fascia. Okay, otherwise it's really hidden. And the Scarpas will definitely descend down into the scrotum. Okay, so it will definitely descend. We won't see that necessarily today. We'll talk about the passing of those levels downstream, but you won't actually get to see it just yet. You're also introduced to the linings of the abdominopelvic cavity. So just like in the chest where we had for the lungs, we had a visceral and a parietal pericardium, or for the heart, we had the pericardium. We had the pleura for the lungs. We have a peritoneum in this region, a visceral and a parietal peritoneum. So it's simply the lining of the inside of the wall. and it's the continuous lining onto the organs themselves, the visceral and the parietal peritoneum. But you have to get through all of these muscles to see down into that layer, so as we move forward, eventually we will get to it. Now there's a few structures to look at here. We've taken that Camper's and Scarpa's fascia, we've got all that good stuff reflected. So now we're looking at the muscles and the fascias of this area. So the first thing I want to mention is a structure called the linea alba. So when you see alba, it's in reference to the color white. Okay? So this is the white line of the belly, the linea alba. It stretches from the xiphoid process down to the symphysis pubis. And it's an avascular line, which means there's very little blood supply, if any, in the true midline of the belly. And that's kind of a big deal, especially for emergency situations, something like where somebody has a AAA, an abdominal aortic aneurysm. Those are fatal the vast majority of the time. But you can cut somebody along this linea alba, and since it's an avascular line, it gives you access to the belly with very little bleeding, very little disruption, if you will. So that's the linea alba. Now, there's only one linea alba, but there's two of these other lines that we look at. They're here and here, and it's called the linea semilunaris, or the half-moon shaped line. And what these lines are, these are hinges for these lateral muscles to have an attachment point. Okay, we're going to talk about these lateral muscles in just a second. But these lateral three muscles will have a common hinge on the linea semilunaris, and there's one of these lines on both sides of the belly. Now, another thing that we'll go ahead and move forward with these muscles, we'll talk first about the external oblique. So just like in the chest, when we talked about the intercostals, we had external intercostals and we had internal intercostals, right? The external intercostals, the direction of those fibers, or like you were sticking your hands in your pockets. Well, the oblique does the same thing. The external oblique's fibers run down and in as if you're sticking your hands in your pockets. But again, the actual muscle itself ends right at that linea semilunaris. Its fascia will continue across to the linea alba, and we'll talk more about that in just a little bit. But the actual muscle itself ends at the linea semilunaris. And then if you look all the way downstream, you'll see that the fascia, the lower fascia from the external oblique, will fold over on top of itself and thicken and forms a structure called the inguinal ligament. So the external oblique's fascia, you see that the fascia is down here, the muscle has stopped, so it's just fascia at this point. External oblique's fascia rolls over, thickens, and forms what's called the inguinal ligament. Now the inguinal ligament has two attachment points. The first one is the as-is, the anterior superior iliac spine. And the second one is the pube tube, pubic tubercle. It's an outpouching of bone just lateral to the symphysis pubis on either side. So you have two inguinal ligaments, it means you have two pubic tubercles. You also have two anterior superior iliac spines. So if you guys ever watch any Matthew McConaughey movie, you know he takes his shirt off frequently. He's like the poster child for this. It's that oblique line that leads down towards the pubic region. You see the muscles, and then you see that oblique line, right? Don't be shy to admit you've seen all of his movies. My wife's seen them all, therefore I've seen them all. Except Magic Mike. We didn't watch that one. Oh, the silence. I was going to see if anybody would chime in on that. They're like, oh yeah, it's good. No, it's not. All right. Is it not that good? There's two, right? And Michael Strahan's in the second one. I saw a commercial.
You said 2 points of attachment again.
Sure. It's the anterior superior iliac spine and the pubic tubercle. That's the Matthew McConaughey ligament, the inguinal ligament. External oblique's fascia folding over on itself. Now we take the external oblique, we strip it away. You're now introduced to the second muscle in line. This is the internal oblique. And just the same as the intercostals, these fibers run up and in towards the midline. Now I will tell you, as you work your way down more towards the pubic region, the internal oblique starts to look a little bit more horizontal and then runs obliquely again. So it is sort of spanning this entire region. The upper fibers are more up and in, the middle fibers are horizontal, the inferior fibers are a little bit oblique as well. But just keep in mind, this is the next level of muscle. Okay, it's the next one in line. Once you reflect the external, then you're looking at the internal. Still hinging at the linea semilunaris. And then the deepest of these three muscles, you'll see here they have the two layers of the external, the internal cut away. So what you're looking at here is the transversus abdominis. The transversus abdominis are horizontal fibers all the way up underneath the ribs, all the way down towards the inside of the inguinal ligament. So I think we mentioned this when we talked about the intercostals, but it holds true again, and actually even more so for the belly. You've got three different muscles, all in the same area, all with the same attachment point as far as the linea semilunaris, right? So what's the point? Why have these three muscles that are just stacked on top of each other, all in the same region? What's the point? Why not just have one thick, huge muscle since they're all sitting there together? The abdomen does have important structures, but so does the chest, right? So I'm fishing for something here. Give me a little bit more. What's a common injury in the abdominal region? Since there's so many pressures, every time you laugh, you cough, you sneeze, you poop, there's always pressures that are happening down there, right? So a hernia is a very common injury that can happen. So thinking along the hernia line, you've got one big muscle that has a weakness in that muscle. Well, all of a sudden that weakness will travel all the way through to the outside of the muscle, which increases the likelihood of a hernia. But if you have three different muscles running in three different directions, it's like a backup plan to the backup plan. So you could damage the transversus abdominis, but the internal external would be just fine, which decreases the likelihood of a hernia. So you've got to invade through three walls of muscle to have a hernia at this point. Whereas if you just had one thick muscle, granted it would be thicker, but the striations of those fibers wouldn't change. So once you invade the striation, it would just continue to erode all the way outward. Does that make sense? So it's a big backup plan. Increases the stability, the protection of those vital structures on the inside. But that is the transversus abdominis. It's the deepest of these three lateral muscles. And again, they all had that hinge right along the linea semilunaris. Well, now you've noticed also that this middle fascia has been taken away. Now that middle fascia has a very specific name called the rectus sheath. Rectus sheath. And it's this fascia that covers the rectus abdominis muscle. So it was the fascia that is sandwiched in between the linea semilunaris on either side to the linea alba in the middle. So that's where the rectus abdominis lives, is in that rectus sheath, which is in between linea semilunaris and linea alba. So what they've done is they've taken away part of the rectus sheath so you can see the muscle, and you'll notice that this muscle is divided up into three portions on the right, and there would be three portions on the left, but it's cut away. So, six-pack muscles. Now you're seeing them. The six-pack muscles are the rectus abdominis. Now again, I love sports, so Terrell Owens. You guys know who this guy is, Terrell Owens? He just got snubbed for the Hall of Fame again. That's just me saying that. But Terrell Owens is a freak. The dude is just a specimen. And he's actually got like an 8-pack. And the reason you can have a variation is because of these intersections. They are called tendinous intersections. That's what sort of divides that muscle into different portions. He has an extra intersection down low, which means he has 4 on each side. And trust me, I saw the dude working out in front of his house, like on video. It wasn't like at his house. But he's out there doing his workout, and you could see like every muscle the dude has. You know, so I saw his 8-pack, and I was very jealous. I mean, we all have these muscles, but some of us have a little bit more camper's fascia. I'm here to there.
I was about to ask you, so is that something you can like work out towards?
Sure. Yeah, but the thing is like everybody has these muscles. Everybody has these intersections. So it's just the amount of superficial fascia you have covering them. You know, so everybody has a 6-pack. You know, so quit your workout plans, right? Quit the cheap diets. Everybody has a six-pack, right? You just got to get rid of the fat that's in front of it so you can see it. Yeah, so feel better about yourself, right? No. It's an anomaly. It's a normal variation. Okay, so you can't make yourself go from a six-pack to an eight-pack. You can be born with that extra intersection that allows it to happen, but again, you don't see any of it if you've got a ton of fat in front of it, right? So, but no, it's just something that you're born with. The tendinous intersection. Tendinous intersection. And you guys will see when you look at the body upstairs, you'll see that the rectus abdominis, the way it's been reflected and dissected, that the intersection is within the muscle. So it's a lot like the linea semilunaris being a hinge, but it's a hinge that's dividing that muscle into three different portions. It's a really neat setup. But the way that we dissect it upstairs is that we cut it away superiorly and reflect it down towards the pubic bone. But for the actions that we mentioned earlier, like laughing or coughing or sit-ups, doing crunches, that's how you really work out this muscle. And it makes sense because rectus abdominis, you're trying to have that erect posture through the abdomen. So doing crunches is what narrows the angle between your ribs and your pubic bone, right? So that's what the rectus abdominis is working, just a straightforward crunch. Whenever you work crunches to the side, that's when you start working those lateral three muscles, the external, the internal obliques, the transversus abdominis, things like that. Now, the rectus sheath sometimes can be a little bit confusing, so you may need to look back at this diagram just for a second. So we'll talk about this one and then we'll jump to the next one. Remember I said that fascia, the rectus sheath, was covering the rectus abdominis on both sides, okay? Well, on the right side, they removed it, but the muscle's still intact. On the left side, they removed it, and they also removed some of the muscle inferiorly. So you'll notice there is an imaginary line here called the arcuate line, A-R-C-U-A-T-E. You want to write that down, the arcuate line. The arcuate line is a division within this fascial plane. And that's important to us when we talk about the formation of the rectus sheath, which is the next thing we're going to talk about. So that's the arcuate line, and this is on the posterior side of the rectus sheath. You tear away the anterior part of it, you're looking at the posterior side of it, and it's usually about halfway between the belly button, the umbilicus, and down towards the pubic bone. So you see it here. We mentioned that, like I said, for the formation of the rectus sheath. Sometimes this gets confusing, okay? So I want to make sure everybody's on the same page. When we are talking about structures above that arcuate line, superior to the arcuate line, right? We're talking about the rectus sheath and the way it surrounds the rectus abdominis. So the rectus abdominis sits in this envelope of the rectus sheath. So above the arcuate line, which is what you're looking at here, above the arcuate line, you have 1.5 layers of fascia that form the anterior part of the rectus sheath, and you have 1.5 layers of this fascia that forms the posterior side of the rectus sheath. Now, what tissues are we talking about here? We're talking about the lateral three muscles, the external, the internal oblique, and the transversus abdominis. So to be very specific, above the arcuate line, all of the external obliques fascia, you see it here, goes anterior. So that's the one. Remember I said it's 1.5 layers. So the one on the anterior side is all of the external oblique. Here's the internal oblique. As we travel towards the muscle, you see that it splits. Half of it goes anterior, half of it goes posterior. So the rectus sheath above that arcuate line is 1.5 layers anterior, which is all of the external oblique, and 1/2 of the internal. The posterior 1.5 is the other half of the internal oblique, and then all of the transversus abdominis going posteriorly. So this is a very good diagram right here. You can see the splitting of the internal. This is a very good diagram to explain to you how the rectus sheath gets its formation. Does that make sense? Above the arcuate line, 1.5 layers anterior, 1.5 layers posterior. And it's the internal oblique that splits and provides tissue on both the anterior and the posterior side. Now below the arcuate line, what happens is that all three layers go anterior. So if you look on this lower diagram, you see again, here's the linea semilunaris, here's linea alba, here's the rectus abdominis. All three layers from these three muscles are now traveling anterior to the muscle, which means behind the muscle there is no longer a rectus sheath. So if you look back at this other diagram here, arcuate line, we've already completely taken away the anterior 1.5 of the rectus sheath, so you're looking at the posterior 1.5 layers all the way down to the arcuate line. And then you'll notice that it looks different below the arcuate line. In reality, it looks much more thin because all of the rectus sheath is anterior. So at this point below the arcuate line on the left side, we've taken all of the rectus sheath away. So the only thing that's left at this point is a thin layer of fascia called transversalis fascia. You see it here, transversalis fascia. Not transversus abdominis. I know it sounds kind of close, okay? So it's not the same fascia, but it's transversalis fascia. So on the body, it looks much more thin posteriorly below the arcuate line. And that makes sense because all the rectus sheath is gone. Then once you go beyond the transversalis fascia, at that point you hit the parietal peritoneum, which tells you you're in the belly. So really the last line of defense before you get into the belly is that transversalis fascia. But this is a good diagram. If you get confused, definitely come back to this diagram to help you understand the formation of the rectus sheath. Any questions there? Nope. Now, dermatomes. One thing, when we talk about a dermatome, of course, we're talking about which nerve is responsible for you feeling touch in a certain area, okay? One thing you'll notice about the dermatomes in this region, we looked at dermatomes on the back, and the dermatomes of the back were fairly horizontal. They get a little bit oblique as you work your way downward, but for the most part, they're pretty horizontal. Here, you're looking in the belly, and again, these are pretty much horizontal, right? You'll notice when we get to the limbs that the dermatome patterns are crazy, okay? There's ways to try to understand the patterns, but it's really crazy because the limbs undergo rotations that the trunk doesn't undergo. So that's why these nerves are able to travel a much straighter path. So when you look at these nerves, it's just sort of showing you how they would travel along with the intercostal groove, and then how they sort of reach their destinations. Usually you see big landmarks like the T6 dermatome is right at the xiphoid process. Another one that you would see is that T10 dermatome right at the belly button. But like I say, for the belly, it's very straightforward. The T6, 7, 8, 9, 10, 11, 12, all of these are just running in line, almost true horizontal as you work your way down. And the next slide just kind of shows you how these nerves travel through. Some of these guys have a motor component to them, and then they become a sensory component as they get closer to the skin. So again, it's just kind of showing you how these nerves sort of pass their way through this region so they can reach their destination. So again, you can see the belly button is here. This is the T10 nerve. You can see that it's running just below the rib, travels a little bit obliquely to get to the belly button. You can see it diving deep below the fascia again, the rectus sheath, before it pops out right beside the belly button. Now there's actually a neat little test you can do to see if these dermatomes are intact. So you can take something like a pinprick or a paintbrush or something, just something where you can irritate the skin just a little, and you can do it beside the belly button, and the belly button will kind of pull to the side that you touch. So it's kind of neat to see somebody's belly button wiggling around, but it tells you that everything's intact because that's the response that the belly button has to kind of pull in that direction. So give a little tickle beside the belly button, it moves to the side, you know T10's intact. But also you're introduced to something here called the L1 nerve. It's got a couple of specific names that we'll talk about more so later. You can see the names iliohypogastric, ilioinguinal. So some of these names are in reference back to the grid when we looked at the grid of the 9 terms for the belly. But for our purposes right now, we can just call it L1 because we will talk about these nerves as they come from the lumbosacral plexus. But you'll notice that they travel downstream. You'll see that they travel downstream here towards an area called the superficial inguinal ring. Superficial inguinal ring. File that term away for a couple of slides until we actually talk about the superficial inguinal ring. But those are the nerves. Specifically here more with the ilioinguinal, makes sense? But the ilioinguinal will travel down towards the superficial inguinal ring. Now, of course, there's a blood supply to this region. You have to have blood supply to the muscles, the three lateral muscles, the rectus abdominis. But the main blood supply that you see here is a vessel called the inferior epigastric. Inferior epigastric. It's a branch coming off of the external iliacs, which is only a couple branches away from the distal part of the aorta. And what it does is it runs inferiorly underneath the rectus abdominis, right along the belly, and then travels upstream to meet with another vessel called the superior epigastric. So we're getting our epigastric names back into play. You guys remember the internal thoracic? We talked about the internal thoracic being held down by the what muscle? Transversus thoracis, that's right. The internal thoracic and the inferior epigastric simply merge together, and that's what forms the superior epigastric. So the superior epigastric isn't necessarily just one vessel. It's sort of the anastomosis or the joining of both of the inferior epigastric and the internal thoracic. So oftentimes it's 3 to 4 tiny vessels sort of merging together. But the inferior epigastric is a big vessel at its origin. Okay, and like I say, it runs right along the belly of the rectus abdominis. So the way, again, that we've reflected the rectus, you should be able to see that vessel as it travels right along the belly of it. But you can see here how it's already starting to split up a little bit for its merger with the superior epigastric. And like I say, it's 3 to 4 branches up in this area. So for identification purposes, it's much easier to see the inferior than it is the superior. But for the written side of this, the take-home message is that you have a direct connection from the internal thoracics, which is basically a connection of the subclavian, right, all the way down to the inferior epigastrics, which is just a couple degrees away from the distal aorta. Okay, so you have this collateral circulation that's coming off of some big structures, some big vessels, and they're actually not too far away from each other, just 3 vessels away if you consider the superior epigastric one of those vessels. Now for the superficial inguinal ring itself, remember earlier we said that the external oblique fascia folds over on itself and forms the inguinal ligament. Well, the inguinal ligament is also a structure that, although it doesn't form the superficial inguinal ring, it does help to give a little bit of shape to it. What the superficial inguinal ring is an opening. It's an opening in this external oblique fascia that allows structures that are deep to it to pass through superficially. What you're trying to notice here is that the superficial inguinal ring is an opening, and we always use the example of the male more so than the female here because of the spermatic cord. The spermatic cord passes through the superficial inguinal ring. So on a guy, it's going to be a little bit larger. It's more stretched out. Okay? So it's a little bit easier to see some of these structures. The superficial inguinal ring, again, is an opening that you see in the external oblique fascia. But to hold that opening, to maintain that opening, it tethers itself to the body, either to the other fascias or down towards the bone. And you'll see that a little bit better on the next slide. But it's showing you right now the passageway of that spermatic cord and its contents as it passes through the superficial inguinal ring downstream. What it's also trying to show you is that there's also a deep inguinal ring. Okay, so the deep inguinal ring is sort of the target area for internal structures to hit the deep inguinal ring to work their way outward through the superficial inguinal ring to reach the outside world. So what that means is that there's a little bit of a connection, a little bit of a tunnel between the superficial and the deep inguinal ring, and that's called the inguinal canal. So the deep inguinal ring, superficial inguinal ring, the connection between those two is the inguinal canal. Now the canal may only be an inch long, okay? It's not very long. And the superficial inguinal ring is much more pronounced than the deep. There's more that's traveling through the superficial ring than the deep. And we'll talk a little bit more about that today, and we'll definitely talk more about it when we do male-female pelvis. But for our purposes now, superficial inguinal ring has more structures passing through than the deep does. So it's a little bit larger, a little bit more stretched. Now when you strip away the spermatic cord and you're looking just at the actual structure of this superficial ring, superficial inguinal ring, you'll see here on the medial side, you have what's called the medial crus. Crus in this business just means leg. Okay, so we have the medial leg of the superficial inguinal ring attaching out towards the symphysis pubis and the pubic tubercle, right in that area. And you have the lateral crus of the superficial inguinal ring over here attaching itself, again, pubic tubercle, but out a little bit more laterally on the pubic bone. Now, the reason that I'm not a big fan of the term crus, because it is very generic. There's more than one crus throughout the body. You've already been introduced to two right here with the superficial inguinal ring. There's also two crura, plural, crus, hate that term. But there's two associated with the diaphragm as well. Remember how the diaphragm travels down and inserts along the vertebral bodies? So crus just means leg. So crus is a generic descriptor, okay? I would much rather you understand that the inguinal ligament, as we mentioned a little bit ago, the inguinal ligament is helping to form part of that lateral crus. The lacunar ligament is tethering the inguinal ligament down to the pubic bone, helping to be the part of that formation of the lateral crus. See what I mean? So when you say crus, it's not wrong, but it's not right. You know, it's just one of those very nondescript descriptors. So if you can be a little bit more specific with it, I definitely would. But the purpose of those guys, again, is to maintain the opening for that superficial inguinal ring. To make sure that nothing's getting compressed or nothing's getting pinched along the inside of it as things are passing through. Here's a little bit of a close-up of the deep inguinal ring. Remember we mentioned that it's not nearly as prominent as the superficial. There's a slide that shows sort of the inside of the pelvis and something that you would look for to be able to tunnel up and find the deep ring. But we don't oftentimes dissect the anterior part of the body and dissect through the inguinal canal to try to find the deep ring. It's just not as easy to see from anterior. It's easier to see from the inside. So from a dissection standpoint, we'll see it just a little bit. But again, it is worth mentioning, just for a landmark's sake, that usually the deep ring is about halfway along the inguinal ligament. So if you put sort of like your pinky on the as is and maybe your thumb on the pube tube, just kind of measure about halfway in between, then that should be right at where the deep ring is being introduced to that inguinal canal. And see, all of this stuff is relevant to us when we talk about hernias, the superficial ring, the deep ring. We already mentioned that hernias are a big problem for the abdominopelvic cavity. So whenever you go in for physicals, sports physicals, especially for guys, they always run their finger up along your spermatic cord. They tell you to turn your head and cough. Well, they're feeling for that superficial inguinal ring. They're trying to feel if there's any type of hernia that's pushing down that invades through that ring. So that's the whole purpose of that, run your finger up, turn your head and cough, right? Now, I'll be honest with you, they don't really do that so much with females anymore. Have you guys sports physicals that they don't do anything like that for you, right? And it's just because of that spermatic cord. It's just a large structure that's just not there for females, so they just don't really test for it. I think they used to do it a little bit, but I haven't heard anybody say they've done that in 15 years or so. Now we transition a little bit to talking a little bit more about the male for a minute. We talk about the testicles. The testes originate on the posterior abdominal wall, and they originate in an area called the retroperitoneal area. Have you guys heard of that term before? Retroperitoneal? Anything that's retro is behind, so some would say my fashion is retro. Retroperitoneal is behind the parietal peritoneum, so it is behind the wall. Okay? So the testicle begins retroperitoneally, and then during development, they start to slide inferiorly along the posterior wall, eventually working their way down into the scrotum. We'll talk a little bit more about some of the specific parts of this as we go into the male pelvis, but there's a structure called the gubernaculum, and that's like the most awesome anatomy term because it's legit, it's a real term, and it's talking about the testicles, so you can't go wrong. Gubernaculum, love it. Gubernaculum, it attaches to the inferior pole of the testicle, and it also attaches to the base of the scrotum. So during development, this structure starts to shorten. Also, the person is beginning to get a little bit taller as well, so they're sort of acting off of each other. As the gubernaculum shortens and as he becomes taller, it helps to pull the testicle down into what will eventually become the scrotum. So if you look at this next slide, it's showing you all of these muscle layers. Here you can see, excuse me, here you can see the parietal peritoneum. So it tells you that this is behind the peritoneum. Otherwise, and here's the intra-abdominal cavity, so the visceral peritoneum would be on organs in here somewhere. That's parietal peritoneum. This is all behind the parietal peritoneum. So it is retroperitoneal. You see the testicle, you see the gubernaculum. Now the gubernaculum is sort of passing through all of these different muscle layers that you see, the transversalis fascia, the transversus abdominis, the internal, the external, oblique, all the layers that we've talked about so far, right? You see that the gubernaculum is sort of passing through all of those and attaching itself to the body wall, which, as you see down at the bottom, will eventually be part of the outer layer of the scrotum. So as this gubernaculum starts to shorten, you see here it's getting shorter, down here it's very short. It's pulling the testicle downstream. So here in the middle, we're seeing the beginning of what will be the scrotum. So as that gubernaculum shortens, it's pulling the testicle downstream, which means it's pulling on this parietal peritoneum as well. So the parietal peritoneum starts to have a pocket that forms, and that's called the processus vaginalis. Vaginalis, vagina, just means a pocket. So this is the vaginal pocket in reference to the testicle. The processus vaginalis. And the way that that pocket is even formed, it's a byproduct of the testicle passing retroperitoneally down into the scrotum. So it's pulling all of these layers downstream with it. So since it doesn't have an attachment to the parietal peritoneum, it's behind it. But since it has an attachment close to it, as a byproduct, it's sort of pulling that parietal peritoneum downstream with it, which forms the pocket. So here in the last slide, you see that the testicle has now descended into the scrotum. That processus vaginalis has also been pulled downstream as well, so you can still see the opening here for the processus vaginalis. You can also see the transversalis fascia. You can see some of these oblique muscles have also been pulled down around the testicle. What you don't see much of yet is a spermatic cord. So on the next slide, it'll show you sort of like a fully descended testicle. Here what you're looking at is the testicle just being passed into the scrotum and not much of a spermatic cord at all. Okay, so just sort of keep those key terms in mind for a second, the processus vaginalis, and then the layers, the three muscle layers and the transversalis fascia. Now there's a condition where the testicle doesn't fully descend, and it's called a cryptorchidism. Sounds a lot like Chris Yorkidism, so I'm not a big fan of it. But it's don't laugh at that. Cryptorchidism is the name of the condition where the testicle doesn't fully descend. It can get stuck at the beginning of the formation of the scrotum, which means everything is basically open at that point and it's strangling the testicle. Obviously, that's a bad deal. There was a baseball player a couple years ago that got hit with a ground ball and actually puts the testicle back up towards the superficial inguinal ring, about split it in half. So I mean, it's a very painful situation. It wasn't the blow from the ball that did it. It was actually the testicle being pushed back to the ring, and then the strangulation that almost strangled it in half. So it was I'm sure that was a pretty painful situation, but it can happen. It can happen. Sumo wrestlers. You guys ever seen sumo wrestlers before? I mean, I haven't seen them like in person, but you know, YouTube's wonderful. If you ever watch a sumo wrestler, they waddle out. You know, they take the flour or whatever it is, and they throw it down on the mat, and then they do a couple of, you know, hike up their legs and stuff, and they pull up their speedo that's like huge, and then they smack each other. What they're doing is when they're doing this to their legs, they're actually pushing the testicles back up. Push it back up towards the superficial inguinal ring, because that way one of the big things to do is to grab the garment around their waist to wrestle, and if things are down low, then they have a chance of being torn. So they're able to push them back up so they don't have a chance to be torn. That's not on the exam. That's just a little bit extra for your information. Somebody's going to look up sumo wrestlers now. All right. So for the fully descended testicle, this should be a normal looking spermatic cord and testicle. And what I mean by that is the testicle has fully descended into the scrotum. You now have a fully formed spermatic cord, and you can see how far this is away from the body wall. Now, around the testicle, you'll notice that there is a pocket, this purple area. This is supposed to represent an open area. This is what's left of that processus vaginalis. However, you'll notice that the top of the processus vaginalis is closed. So now it simply changes names to the tunica vaginalis. Tunic means coat. So now this pocket, has fully walled itself off and has become the coat, the tunica vaginalis, and it now surrounds the testicle. So just the same way that we had a visceral and a parietal pleura, pericardium, and peritoneum, we have a visceral and a pleural, or a visceral and a parietal tunica vaginalis, because there are two layers to this pocket. You have the one layer that's along the inner side of the pocket, or the coat now, and you have the other layer, the visceral, which is directly on the testicle. So the processus vaginalis changes names to the tunica vaginalis once it's fully sealed, and then it surrounds the testicle. Now, issues can be if the processus vaginalis does not close off. Again, that means that's the open channel all the way back to the superficial inguinal ring, back into the pelvis. Okay? So people like the sumo wrestlers, they force that processus vaginalis to remain open. So they allow the testicle to be pushed back upwards. Okay? But a normal circumstance should be that this is completely walled off, processus vaginalis becoming tunica vaginalis, the coat. Now also notice something as well, these different fascial layers. Let's start with the external oblique. Okay, here's the external oblique's fascia. It's already done its thing for the inguinal ligament. External oblique's fascia comes downstream. At this point, you'll see this is the area of the superficial inguinal ring. At this point, the external oblique's fascia simply changes names and becomes the external spermatic fascia. See it here. So external oblique becomes external spermatic fascia when you hit the spermatic cord. Internal oblique, you see its muscle here, you see its fascia as we go downstream. It becomes a muscle layer called the cremaster. Now the cremaster is, without getting too much into male-female pelvis, the cremaster is the muscle that's responsible for pulling the testicle closer to the body wall for temperature regulation. Okay? So the cremaster is an actual muscle layer that sits inside the spermatic cord. And that is nothing more than the continuation of the internal oblique. Now, transversus abdominis wimps out at the superficial inguinal ring. It does not continue downstream, so you can see it here at the level of the superficial inguinal ring, and there is no communication downstream. So, transversus abdominis here, and then it ends. The transversalis fascia, that last line of defense that you only really see once you're below the arcuate line, it continues downstream and changes names to the internal spermatic fascia, down inside of the spermatic cord. So you've got three different layers within the spermatic cord. One of them has more of a muscle layer to it, the cremaster. The other two are just fascial layers, which, unless you butterfly the spermatic cord, you're not going to see them. You can see a little bit of the muscle fiber from the cremaster, but it's hard to differentiate between the external and the internal. But you do need to understand that that testicle, as it passes downstream, is pulling all of these different layers, right? So we saw how it was pulling them down, and they change names once they get into the spermatic cord. I think we talk more in depth about that once we do the male pelvis, so I'm just going to leave that alone for now. Any questions on that? Now there's an area that we're looking at here. This is actually inside of the belly, looking outward, looking forward. Here's the symphysis pubis. So if we were standing inside of the belly trying to look out through the front of the person, we're looking at an area here called the inguinal triangle. You see the name, inguinal triangle. Now the inguinal triangle, of course, has three borders to it. You have the rectus abdominis. See it here? That's the lateral border of the rectus abdominis. You've got the inguinal ligament. And you also have the inferior epigastric. There's the vein that's associated with it as well. If you just say artery, that's fine, but it's the inferior epigastric vessels. Okay? Rectus abdominis, inguinal ligament, inferior epigastric. The purpose of talking about the inguinal triangle is that this is a very common place to see an inguinal hernia, because there is a natural weakness here because the muscle, the rectus abdominis, has ended. So it provides this weakened area just above the inguinal ligament as well. So if there is a hernia, which in this case is either fat or gut, it's really only one of the two things it could be, unless there's something like an accident, something else goes wrong. Just a normal acquired hernia is usually just fat or intestine. So if there's a hernia that travels through this triangle, it's called a direct hernia. A direct hernia goes directly through the triangle. And another way, a tombstone name for this triangle that's still used is called Hesselbach's triangle. Hesselbach's. Pretty sure it must be the guy who found it. That's what they name stuff after themselves. They're a little pompous that way. But Hesselbach's triangle is another name for the inguinal triangle. So a hernia that goes directly through the triangle is called a direct hernia, which means an indirect hernia is a hernia that travels just outside of that, which is usually just lateral to the inferior epigastric, which happens to be the deep inguinal ring. So as we've already said, the deep inguinal ring is the open area that is a weakness that takes internal structures, allows them to travel through the canal out towards the superficial inguinal ring. So if you have a hernia of fat or gut that goes outside of the triangle, this is the next best place for it, because this is the next weakness that it would see. And it can travel through that deep inguinal ring, through the inguinal canal, out the superficial inguinal ring, and then especially for somebody, a guy, it could travel down towards the scrotum, down and right along the spermatic cord down to the testicle. So that's why during those physicals, the sports physicals like we were saying, you run your finger along the spermatic cord and you ask the person to bear down or cough. You just want to increase that intra-abdominal pressure to see if there's something that's traveling along that deep ring, pushing down towards the superficial ring. So that's the whole mechanism behind that. Yes?
So what is direct hernia?
I'm sorry, say that again.
Direct hernia be worse than direct hernia?
It depends on what it is. Strangulated bowel is bad no matter if it's a direct or indirect hernia, because if you have strangulated bowel, you've lost innervation and blood supply, so it's gonna die pretty quickly. So I would almost argue that if it's bowel, the indirect would be worse because the deep ring is very tight. It's a small area, so it would probably strangulate quicker in the deep ring than it would just sort of making its own way through the triangle. If it's fat, I mean, they're both painful. If it's fat, a direct can be a little bit more painful, but if it's bowel, the issue with the bowel is probably a little bit greater if it's indirect. Both have to be repaired, usually surgically with mesh. So they go in and put a mesh patch around the area, especially if it's an indirect. They'll go in and cut a hole in the middle of the mesh to allow the spermatic cord to run through, and then they tack in the mesh around the cord right at the level of the superficial ring. Has anybody had a hernia repair before? No? I've had two. I've had one on each side. Sometimes kids are born with them, especially guys, because like we said, the weakness, that natural weakness that's there because of the testicle. So on one side I was born with the hernia. The second side was acquired. So I know the acquired one was painful. You could feel it give, you could feel it pop, and it was just immediate, like a deep burn, a deep pain. So then anytime I would call for strain, I could feel, it felt like something pushing down. So it's a very clear, noticeable pain, you know, especially since, you know, doing what I do, I knew what to look for. So I knew what I had done immediately. But it's a pretty painful thing. Any other questions about the triangle, indirect hernia, direct hernia? Now the last couple slides I just mentioned briefly because we've already talked about most of this stuff, and we will talk more about the male-female pelvis in a couple of weeks, but this is just sort of an oblique view looking at the inside of the pelvis, and it's trying to show you the pathway again of that superficial and the deep ring. You see the inguinal canal here, and it's just showing you that for the male, one of the biggest structures that travels up towards the deep ring, you'll see it here, is the ductus deferens. I know oftentimes it's referred to as the vas deferens. You may have learned it as vas deferens. Vas means vessel, and they're trying to get away from that terminology because the vas deferens or ductus deferens doesn't carry blood, right? It's carrying something else. So they're trying to call it ductus deferens now. So the ductus deferens is the structure that you would look for on the inside of the male pelvis to travel up towards the deep ring, because it is one of the structures that contributes to the spermatic cord. So that tells you it's got to travel through the deep ring out the superficial to reach the spermatic cord. Whereas on the female pelvis on the next slide, you'll see that there's an anchoring mechanism for the uterus called the round ligament of the uterus. And the round ligament is what you would look for on the female that travels up towards the deep ring. Now it also travels through the deep ring out through the superficial, but the difference is, of course, there is no spermatic cord, so it's just going to exit the superficial ring, fan out, and attach itself to the pubic tubercle. Because again, like we were saying, that's an anchoring mechanism for the uterus, okay? So as soon as it comes out of the superficial ring, it fans out and attaches. It's kind of tough to see, especially right at the superficial ring. So it's a little bit easier to see that relationship with the deep ring. Now, we talk about homologous structures. The round ligament of the uterus and the ductus deferens are not homologous structures. They travel the same path, but they are not homologous structures. The round ligament of the uterus, again, being that anchoring mechanism, is homologous to the gubernaculum, because the gubernaculum was that anchoring mechanism for the inferior pole of the testicle. So just because they run in the same path doesn't mean they are homologous structures. Okay, round ligament of the uterus and gubernaculum are. And I'll probably leave that there with the pelvis because, like I say, we talk more about those guys later on. Pretty straightforward. You guys have any questions? If not, oh yes, go ahead.
So it's a third lab lecture going to be.
Is the third?
Like the lab part that we did for testimony. Is that going to be on our next test?
No, no. No, the question was, is the third lab from last week that we omitted from the last test, you're not gonna see it again. It just, we don't have time to go back to it. So I hate there was a mix-up, but I learned from it. Sorry. I'll see you guys Thursday.